Good afternoon. My name is Larry Cripe, and thank you for joining our conversation today. You're joining an ongoing conversation that Rich, Ann, and I have had over the last 20 years. The conversation we engage in is about what happens when patients, their family and friends, and their clinicians gather in conversation, and how can we make these meetings, these conversations more meaningful. During the time we spend together today, we encourage you to submit questions or comments because we know there's a lot we can learn from you. We hope, like all good conversations, we'll find out what is of interest to you and speak to your questions and comments. So please feel free to submit as comments or questions come up. My name is Dr. Larry Cripe. I care for people with blood cancers at the Indiana University Simon Cancer Center. My research goals for the past several years have been to develop resources to help clinicians, patients, their families, and friends have better conversations. Many of these resources are designed specifically for patients and caregivers. A number of years ago, early in my independent practice, I became aware that I was not well prepared for the conversations I had each day with people facing significant health challenges. Around that time, I had the good fortune of meeting Ann and Rich, and over the years, we have collaborated on multiple research projects designed to think about and improve conversations. It's my pleasure to introduce Anncottingham, who will give a brief bio sketch of herself.
Hi, my name is Anncottingham. I do health services research with Riga Street Institute and the IU School of Medicine. And my research focuses on communication between patients and clinicians and caregivers and the healthcare team. One of the goals is to identify communication strategies and techniques that would lead to respectful and effective interactions. I've worked with Dr. Cripe and Dr. Frankel on multiple studies. And I'm here today because I have interviewed hundreds of patients and caregivers and physicians and listen to their stories about their experiences of illness and care. And in these conversations, I've learned both what patients and clinicians appreciate and what they find challenging. And so some of these things are what we'd like to touch on today. And so, Rich, would you like to introduce yourself?
Certainly, Ann. So I'm Rich Frankel. I'm professor of medicine and geriatrics at Indiana University School of Medicine, where I lead the Aspire program, co-lead the Aspire program with Anncottingham. Aspire stands for the Advanced Scholars Program for Internists in Research and Education. And I've spent the past 45 years as a medical educator and researcher. My focus has been on clinician-patient communication. And about 25 years ago, developed something called the 4 Habits of Highly Effective Clinicians with a colleague from Kaiser Permanente. And we've taught this approach to conversations with patients to about 25,000 physicians, both here in the United States and abroad. And I had the great good fortune to meet Dr. Cripe very shortly after I arrived at IU in 2002, and we have been dear friends, research colleagues, and collaborators ever since. And it's been a joy to work with Dr. Cripe, especially as he's developed his approach to working with patients with life-limiting diseases. So I'm delighted to be here today and looking forward to the conversation.
Thank you, Rich and Ann. I want to emphasize to everybody, we do not have prepared or rehearsed remarks or presentations. So once again, please feel free to send questions. Our goal is relatively straightforward. We want to answer a question. How can we have more good conversations? Let me explain. In the course of my average day, I have good and I have not so good conversations. As a rule, however, I am unable to often in the moments understand or appreciate what was different between those two types of conversations. For example, you might think that difficult topics make for not so good conversations, but that's often not the case. Often the topic was easy or the conversation should have been easy, but I leave the conversation feeling that something was not accomplished that should have been accomplished. And this is part of what Ann and Rich and I spent a lot of time talking about. And so we're going to start our conversation. I'm going to propose a question to Rich and Ann. But just to let you know, we're going to divide this into three broad categories. We're going to talk about questions during these conversations. We're going to talk about conversations about goals. And then we're going to talk about the emotions that surround and take place during these conversations. So we're going to start out with the first question, and that is to Ann and Rich. What is a good conversation? In your experience, what makes for a good conversation in this setting? Ann, why don't we start with you?
Sure. So it's interesting because from the perspective of patients want to feel heard. They want to feel that their clinician understands their concerns, is interested in their concerns, and addresses what's bothering them, which may or may not be the specific goal the clinician had for the conversation. So patients want to feel heard. They also want to feel cared for. They want to feel that their clinicians care about them as a person, and their clinicians are interested in their wider life story and the context of their illness, which may impact the kinds of treatments that would be important for a patient. If the patient needs to walk their dog every afternoon, certain treatments may lend themselves to allowing that and others may not. So the ability to share the broad context of what's important to that patient is something that many patients want to feel as part of the conversations that they have. Clinicians, of course, want to know about the patients, want to understand what's going on with the patient, and really appreciate straightforward discussions by the patient of what their concerns are. And so oftentimes a patient may be holds back a little or is shy about sharing some pieces of information. Clinicians want to have straightforward understanding about what that patient is concerned about, specific questions, ideally, that are shared up front and not toward the end of the conversation. And those are part of what I think make the clinician feel that they're able to really address what is concerning to that individual patient.
Thank you. Rich?
Yeah, that's exactly right, Ann. And the question that we might ask ourselves is, how is caring actually communicated? You said patients want to be seen, heard, and understood. How does that happen? Well, it happens on the clinician side by nonverbal behavior. Eye contact is one of the main ways in which caring can be communicated, not spending a lot of time looking at the computer, but spending time looking at the patient. Body orientation is another way, facing the patient. And there are three general buckets, if you will, for the ways in which caring is communicated. The first one is connection. How do I connect with the patient? Do I connect personally with the patient? Do I learn something about them? Am I curious about who they are and what their hopes and dreams are? The second is co-constructing the illness narrative. And in the olden days, this was known as information extraction, that the clinician would just pull information out of the patient. But we now know that co-construction, that is the physician or clinician having an active role in learning about and constructing the story of illness, is a very important dimension of caring. Not interrupting the patient during the gathering of information is one main way in which that happens. And then finally, collaborating for care, making sure that what you are expressing to a patient is understood, and that there's agreement between the clinician and patient on the nature of the problem that's being addressed and the solution to that problem. All three of these are important dimensions of the way in which caring is communicated.
Thanks. So before, I think those points were really great points. Before we talk specifically about questions, I do want to just ask each of you to reflect on your answer. And so I think part of our goal is to say what is trying to happen in these conversations and how can a patient or family member help it to happen, right? So Anne and Rich, as you think about the things you just mentioned, just give us one example of something that would be relatively easy for somebody to help the clinician make sure it happens in the encounter.
Sure. So when you're a patient visiting the clinician and the clinician asks, tell me what's wrong, for example, you can share the immediate symptom that brought you into the office, but it would benefit the clinician for you to share a little bit more, tell a little bit more about how you've been feeling, when these symptoms first started to develop, a little bit broader context about what's been going on with you. Don't feel that time is so brief or compressed that you have to just jump right to one specific piece of information, but you can share a little bit more about the context of what your illness is. Also, be honest and accurate. Don't be afraid to share any piece of information that could be relevant to this. Individuals many times are concerned about what they say to their clinician or how the clinician might take a certain piece of information. Don't be embarrassed. And finally, oftentimes clinicians say it's so helpful to them if the patient arrives at the appointment with questions. So come prepared with what you want to know, what you need to know, and share those right up front. It is most beneficial for the clinician to know right off the bat what you're concerned about than to hear about it at the end of the appointment when they're getting ready to move on to another patient. So those are a few ideas.
Great, thank you. Hey, Rich, I'm sorry to interrupt. I was going to ask you specifically, we have a question about the computer in the examination room. So, and navigating that presence of that third entity, so to speak. Do you want to speak to that for us, please?
Yeah, certainly. So the computer is a relatively new participant in the clinical encounter. And up until about 15 years ago, while computers were being used and electronic medical records were being used, the computer wasn't in the exam room. It was in the back room, and the clinician could review the patient's chart before coming into the room. What's changed is the pressure to document while doctoring. And so in certain organizations like the Veterans Administration, records have to be completed within 24 hours. And so a lot of clinicians have taken to doing their documentation while they're seeing the patient. The problem that raises is that you can't pay attention to the patient and pay attention to the medical record at the same time. It's either or. It's not possible to do both at the same time. That having been said, most clinicians have little or no training in how to use the computer effectively during the encounter. And so as a patient, you can be helpful by making this a topic of conversation by saying, I'd like to see what you're typing so that I can make sure that we're on the same page in terms of what's in the record. Or, I'm feeling a little bit uncared for here. Could we just talk to one another face to face for a few minutes? So I think that there are good ways without being judgmental that you can move the conversation from feeling unhappy with the way in which the computer is being used to a partnership model. We teach what we call the golden triangle, which is the computer, the clinician, and the patient are in an arrangement which is a triangle so that the patient can see what's being typed. And we teach clinicians to verbalize how they're going to use the computer during the examination. We know that some physicians spend as much as 80% of their time interacting with the computer screen and only 20% of their time interacting with their patients. And we also know that that's a source of dissatisfaction on patients' part. And so the question then becomes, how can we help physicians to spend more time in the actual course of doctoring, that is being face-to-face with the patient? And there are good training programs that we and others have developed to do that.
Thank you. As I was thinking about that question, it strikes me that this is we're in evolution, and I think about how do we integrate that into the examination room, because there are very powerful benefits of it, right? Independent documentation. I mean, I love the fact, for example, if I'm not sure or there's a discrepancy in how I remember things, often I can pull up with the patient looking at the record for that date to see when the CAT scan was done or what the results were. So I think it's about learning. And I say that because I think that my colleagues and I would certainly welcome, as Rich suggested, some of your reactions about how can we best use that in the interactions with you. I'm going to, just to keep us on time, I'm going to talk about questions, because I think that to me is a topic that's of great interest, because as Ann has alluded to, I think questions are a great way to alert the clinician what you're most interested in. And so as I think about this, I'm going to just throw out an idea for Ann and Rich to respond to. And that is, at a minimum, I think when you're thinking about questions, what questions you have, you should come to the conversation with at least a blank piece of paper and a pen, and have that around days before your conversation or your appointment, and sketch out or just drop things in there. So it may be too much to think about coming to the conversation with a whole list of questions, but certainly a few questions I think would be possible. The other point about the paper, I think, is you can always say to your clinician, what questions should I be asking at this point, right? So we often know as clinicians, we're offering a lot of information that engenders a lot of questions, and it feels overwhelming to everybody. But I think carrying with a blank piece of paper or paper with your questions on and a pen will give you some space to help answer your questions. We did have a question about somebody saying, how do I deal with a doctor who may not like questions? And I would say that as a rule, I think your doctor probably likes the questions, but is just overwhelmed with the number of questions. And so one strategy I was thinking about is to come with your questions and then have a negotiation about what are the questions that can be realistically answered during that visit versus which questions will be delayed for another visit or even scheduling a different visit. But Ann and Rich, do you want to, before we move on, talk briefly about that?
Sure. Rich, do you want to take that first, or?
No, why don't you go ahead, Ann?
Sure. So just to reiterate what Dr. Cripe shared, coming to the appointment with questions is helpful not only for the patient, but the physician. They need to know what you're concerned about. They need to know what's on your mind. And it's very beneficial for you to go in there with a plan, with an idea of what kinds of information you need, because studies show the majority of patients often leave the clinical visit without fully understanding what transpired or what their current health status is or what their next treatment step is. And so ensuring that you do understand what's going on in that meeting. Asking questions not only that you've brought from home, but as you're involved in that conversation and something is confusing or not clear, it is very fair and appropriate to ask about that. You can say, for example, let me repeat this back. Here is what I thought I heard you say. And then let the clinician tell you if that information is correct or not. But making sure that you leave that appointment fully understanding what you talked about, what the treatment plan is really critical for your own health. We also just received a question. What if you're the clinician and the patient is asking questions that don't feel relevant to you or that are taking you afield from what you feel you need to talk about? What do you do? And I'd like to fold that into our conversation, Rich and Larry, as well. So from my perspective, as we said at the beginning, patients want to feel heard. If they're sharing a concern in what is often high anxiety situation for them in that clinical interchange, it probably is a very real concern. And probably the sooner you address that concern, you listen carefully and acknowledge that you've heard what they're saying, the more quickly you'll be able then to move on to the kind of information that you feel is more relevant for their field. I'll end there and see what Rich and Larry would like to say.
Yeah, so that's great, Ann. And I just want to follow up by saying questions are very powerful social actions. Think about a court of law in which prosecuting attorney says, where were you on the night of August 11th? You don't have the right to ask a question in response by saying, where were you on the night of August 11th? So we know that in certain circumstances, questions really determine what comes next, what's appropriate as a next action on the other person's part. We know from research in this domain that anywhere between 91 and 99% of what physicians do during an encounter is to ask questions and look for responses. That means that patients are doing very little question asking. So there's been some research in which patients have been coached to ask more questions. They're called activated patients. And so on the basis of a 20-minute coaching intervention in hypertension, diabetes, ulcer disease, and cancer, the coaching resulted in more questions being asked and better outcomes. The outcome in cancer actually was a trend. It wasn't statistically significant. But patients who asked more questions had a tendency to be living longer than patients who didn't. So we know that asking questions has a positive benefit in terms of outcomes of care. Now, actually asking questions in a context in which the other person is asking question after question after question poses some difficulty. And that's where the coaching to become more activated comes in. Your health is going to benefit by asking questions. That's a real motivation to want to ask more questions. I think, as both Ann and Larry have said, being prepared for the visit is one good way in which you can ask your questions, and actually practicing with someone who either is not open to being asked questions or is open to being asked questions, but is surprised when you do it, is one way of becoming more comfortable. After all, we teach the question asking on the other side of the stethoscope so that physicians learn, my job is to ask you question after question after question.
I think what I would say is we're not creating an obligation, but I think what we're saying is there are opportunities. And I think what's not well understood is that we negotiate about what the conversation is going to be. And I suspect what we're saying is that if someone comes prepared with questions, that's a powerful way to change the agenda or what's going to happen. That doesn't mean you have to show up with questions. As Ann mentioned, you can think about the questions that arise during the encounter. Or I think, and this is not, I think Rich or Ann came up with this, is you can say to the clinician, what question should I be asking? I think all questions are fair and valid and important, but I think everybody in the conversation should recognize that sometimes there's going to be a need to negotiate what questions are going to be dealt with when. Because I think both in terms of time and in terms of being overwhelmed with the answers. So I'm going to move us along. And one of the topics that we talk a lot about and we're developing resources for is this topic of goals. How do we talk about our goals? How do we share our goals? How do we help one another understand our goals? And Ann, I know this comes up in a lot of the interviews you do. So if you want to start out and give us some perspective on that, I'd appreciate it.
Sure. So one topic that I hear consistently from patients and from caregivers is that in the brevity of the office visit, clinicians often do not ask the patient about what their broader goals are. Sometimes they don't ask specifically about the treatment goals. There may be an assumption they know what that goal is, but nearly all the time it feels that they don't ask about the patient's personal goals. And many times those personal goals are relevant to how a particular disease or illness would be treated. If a patient has another factor that they want to have addressed, something else that's critically important in their life, if they want to live long enough to see the child graduate from high school, or if they have another comorbidity that they would like to have addressed, but taking care of that comorbidity could influence the treatment to the current illness. That's important for the clinician to know. And so if the clinician doesn't ask that question, it is okay to share that information as you describe your broader concerns and issues in the appointment, because having all of the information related to you is very important for that clinician to come up with the right care and treatment plan in conversation with you. Rich, what are your thoughts?
Well, I agree with you, and that in any way that it's possible to get information onto the floor that's important to you, that's a good way to act in the encounter. I think it's helpful to think about what is it that I hope to gain, or what is it that I hope the other person understands about me and my life goals or my treatment goals. And if the conversation has become too transactional, just information sharing back and forth without reference to the broader sense of how this fits into my life or how this fits into my life world, I think it's useful in an efficient way to look for opportunities to expand the conversation to be more interactional rather than just sharing information back and forth.
I would add to that, I think that perhaps people don't realize how important these goals are to the decision-making process. And oftentimes people will say to me, well, you're the expert. And I will say, I am the expert in almost everything except what's important to you and what you value and what benefits you're looking for. So the main point I want to make at this juncture is just that you are the expert in your life and in your goals. And it's easy to have that swept aside with all the technical things that happen in encounters, conversations, and all the nuts and bolts. but especially for people who end up requiring multiple different types of chemotherapy because chemotherapy hasn't accomplished what we want, each step of that path, those goals become more and more critical. And I think that it's a challenge, but perhaps one thing you could do is you could say, what do you think my most important goals are? I mean, I think sometimes it's hard for us to articulate what our important goals are, but just asking your clinician or your family members to summarize, well, what do you think is important to me would be one way to do that. Ann and Rich, any other thoughts about how somebody could introduce the topic of goals in the conversation if they feel it's not being introduced?
I think one thought is to be very specific as you're talking about care and treatment. If that care and treatment seems to hinder goals that are very important to your life, bringing it up at that time and saying, will this course of treatment allow me to do X, Y, and Z? Or is there another course of treatment that might not be quite as effective, but might allow me to do some of these other things that are critically important to my life? I think that would be a really nice way to introduce the comment and discussion about your goals if it hasn't been brought up in other ways.
So I agree with what you're saying, and I want to go back to a comment that was made a little bit earlier about redirecting a conversation in a respectful way, especially when it's gone off topic. This is from a clinician, I believe. So there is a concept called conversational repair. And this is a really useful concept because I might say to Larry, I think you misunderstood what I was saying about the importance of fishing in my life or whatever it happens to be, which creates the opportunity for Larry to say, oh, well, please tell me what is it that's important to you? So this idea of conversational repair going both ways, I can say to Larry, you misunderstood me. He could also say to me, I misunderstood you. So in terms of how to direct a conversation in a respectful way, I think this idea of conversational repair can be used. So a patient who's gone off topic, you can say, that's really interesting what you're saying about fishing, but I wonder if we could return to the topic of your treatment right now. And if there's time, I'll be happy to talk. And I'm interested to know about why fishing is so important to you. So it's possible to be respectful and to redirect at the same time.
Great. Before we go to the final topic about emotions in these encounters, there have been a couple questions around what I'm going to liberally say is a question of life expectancy and how do we communicate life expectancy, what happens during these conversations about life expectancy. One question basically asks, is it challenging? And I would say, yes, it is challenging for everybody. And along the lines of redirecting, repairing, setting the agenda, it really takes all parties fully involved to figure out how to discuss life expectancy. And that I think it rarely starts out with someone saying, what is my life expectancy? Typically it's negotiated about what really are the questions leading to. So it is important to have those discussions. One way to do that is to ask early and train your clinician or train with your clinician about how to have those conversations. I always think anytime a life expectancy conversation is going to happen, just by the nature of the conversation, it's critical to have as many ears, as many people on deck, listening, hearing, questioning, clarifying, to make sure the information is being perceived accurately. And I know, once again, in your interviews, this topic comes up frequently about the patient or caregiver trying to figure out, how do you know what the life expectancy is?
It does. It's interesting because oftentimes it's not discussed. Oftentimes the clinician does not bring it up. And so the patient and caregiver are left to try to figure it out on their own. And what they've shared, some of the ways that they identify what the patient's life expectancy might be, are just their off the cuff sense of, does the patient seem healthy? Is the patient doing the usual things they would normally do? Sometimes they'll cite that a lab test came back and was looking really good, even though what they don't say is, or don't know, is that that lab test looking good has nothing to do with the patient's life expectancy, but they'll interpret it, or they'll think that it does. They'll even interpret the apparent emotions of the clinician or the clinical team. If they seem upbeat, they'll take that as a potential positive sign about the patient's prognosis. If they seem a little down, they'll wonder if that has to do with the patient's prognosis. So, while the clinician may or may not be sharing details about prognosis, the patient and the caregiver are reading those details into whatever is going on in their clinical experience. And I think that's an important thing for clinicians to be aware of. And sometimes, they won't ask because naturally there's some anxiety around that. Sometimes they will ask. And most of the time, patients and caregivers, when they ask, they want a straightforward response. And so that's something that they sometimes get, they sometimes don't get. But important, I think, for clinicians to realize in the interviews that I've conducted, I would say most of the time, they want to know what their prognosis is in a straightforward way, to the extent that the clinician is able to share that.
The only thing I would add, and Larry, is how difficult it is to take what is true statistically and to have a conversation about what's true personally. So we speak in statistical probabilities. Patients want to know what is true for me. And that's a very difficult to cross, and to get across the idea that there's uncertainty on the individual level because we're talking about a statistical probability.
Right. I think that's very true. I think that I think it's also about thinking, everybody in the conversation thinking about, what are the implications to the answer, right? So if someone says, what do you think my life expectancy is? I do think it bears some thinking about, well, how will we use that information? Will the information change the actions we're doing? Will it change the preparing we're doing? Will it change the planning we're doing? And so there's a lot in that question. I think you would agree in that it's not just the statistics, but it's a sense of, how well am I doing? What should I be prepared for? A new question came in that I think is very interesting. So I will just read it out and then ask Rich and Ann to comment. How does a patient deal with a doctor who always comes into the room exuberant with compliments about how great you always look and how well you are doing, before asking you, where are you at and how are you feeling? As a patient, I don't want to burst their bubble or disappoint them by saying how I look is not how I'm feeling. I think that question also uncovers the whole issue of expectations and whose expectations are really being met in these encounters. But Rich, why don't you start out and then Ann can follow up?
Sure. So this also relates to a previous question about how can I be honest with my patients about what's going on. And I think that the most straightforward answer to this question is not to take on the role of a mind reader and imagine what's going on for the patient, but to start the encounter with a check-in. What's going on for you before I express my exuberance? If you're feeling really crappy, my exuberance is going to be misplaced, possibly misunderstood, and unappreciated. So I think coming into the room in a more neutral stance, trying to find out from the patient, in the case of the pediatric patient, asking the parents, what do you know? The parents will then tell you basically how to approach their understanding, and their understanding may be emotion laden. It may be, well, we know that our child may have a life-limiting disease, at which point you can agree with the people or with the parents and say, so where does that leave you? How is that affecting your day-to-day lives? And that's one good way in which the emotion that they're experiencing comes to the surface and gives you the opportunity to respond to their emotions. We teach that you should always respond to patient emotion wherever and whenever it occurs. There is a great fear on the part of many practitioners that if I deal with somebody else's emotions, two things may happen. One is I may have the same emotion they're having. So if they start crying, I may start crying. This is true for a lot of younger professionals. The other is that once I open Pandora's box to their feelings, I'm going to be stuck in the exam room for the next 3 hours. And the actual evidence goes in the opposite direction, that by dealing with emotion when it occurs and how it occurs, the visit is actually much more efficient than putting it off or not dealing with it at all. So those are some thoughts about emotion.
And I want to focus your answer a little bit more. And imagine for us that you're in that situation where you're not feeling well, and yet your clinician comes in and talks about how great you look, how in that moment, do you have a sense of how you might deal with that?
Sure. And I think this is a common issue, is being concerned about the impression that you're making on the clinician. For patients, that clinician is in a more powerful position and in a sense holds your life in their hands in terms of their ability to care for you, to treat you, to find the right treatment. It is not an equal power dynamic, and it is not unusual for patients to be very concerned about what they say to their clinician or the impression they give their clinician. However, it is critically important for that clinician to honestly understand how you're feeling, what your symptoms are, what you're experiencing. And so my advice would be to break through the fear you have about maybe disappointing the clinician, that you're not feeling the way they are interpreting your appearance, and tell them straight up what the truth is, what your honest symptoms are, what your honest feelings at that point are, and don't be afraid to share with them what's really going on with you, because in the end, it will benefit your health, and they really want to hear that information.
Thank you. So we're almost out of time. So I think I'd like to start with each of us just giving one final impression or words of encouragement or insight into how people can have more good conversations, good being what conversations they want to have. So Rich, Ann, and then I'll finish up.
I think the main thing is the role that I, as a patient, can play in our partnership half of my health, and having the courage to be straightforward about what I want from that partnership, what I need from you is, and maybe doing a little exercise for yourself. Think to yourself, what I need from you is X, Y, and Z, and practice it with a loved one. And then when you go into the exam, deploy it, use it if you're feeling as though you're not getting what you want and what you need.
And building on what Rich said, my thought is be honest and accurate with your clinician. Don't hold back because you're concerned about the impression you might make on them. The clinician needs to hear how you're feeling and what you're thinking, including your physical symptoms and your goals and your personal and life goals. So be honest, be accurate, be straightforward, and tell the clinician what's on your mind during these important visits. Don't be afraid.
Thank you. And I'll echo that in a slightly different way and say that I know the best conversations I have happen when the patient or a caregiver, family or friends asks me or lets me know what it is they would like. There's no doubt that I was trained in a certain way to think about these encounters. And if the default is how I was trained, it's probably not the most meaningful conversation. But if I know that there are things I'm doing that are missing the point, or better things that I could do that would hit the point, and I know a better sense of what you want to accomplish during that time with me, the conversations go incredibly well. And Rich and I are mindful that we don't want to create a sense that it's your obligation to do that. But I do think it's easier than it seems. And I think, as I think about my career, the notes I've received when people have said, I wish it hadn't happened that way, or I wasn't comfortable, those are painful, but they're very instructive. So thinking a bit about what kind of encounter will make it a good encounter for you and what you would like to accomplish during those encounters will be tremendously powerful, I believe, in helping you achieve your conversational goals. So thank you for joining us. Michael, are we